Hello and good evening. My name is Sean Carrie and welcome to our third summer European Rhinological webinar series. And this evening we are going to be talking on and focusing on epistaxis. And of course, epistaxis can be very straightforward to manage, but it can, on the other hand, be incredibly challenging. And decision making is clearly key in this area. So this evening we have three panelists from across Europe, all very experienced clinicians with regular management of this sort of condition, and they're going to share their perils and pitfalls of managing epistaxis in the COVID-19 era in particular. So I'd like to introduce them to you. Our first speaker this evening is Urban Geisthoff from the University Hospital in Marburg. Secondly, we have Gwijde Adriaensen from the University Medical Center in Amsterdam. And finally, we have Thibaut van Zele from the University Hospital in Ghent in Belgium. And as ever, we have Pavol Surda, my colleague from London and president of the ERS and juniors. Just one little disclaimer, of course, and that the views of the audience, of the panelists, are their own views and not necessarily those of the Rhinologic Society. And can I just remind you to use the questionnaire function on the Q&A as we go along, because I'm sure this will generate lots of questions, and it's always interesting to hear what you have to say. So I'll pass over now to Urban to present his first presentation.
Many thanks for the invitation. I'm happy to talk here. And let me see how I can start. Yes, my screen. So, I'm happy to talk about epistaxis. And I'd like to focus especially on three slides, which are especially marked. I'm from Marburg in Germany. Where is that? That's a little bit north of Frankfurt, in the middle of Germany. It's a very old town with a nice castle, which also in the past was part of university. And this is our university hospital building, which is a little bit outside the city.
Urban, we don't actually have your screen on at the moment.
Oh, sorry. Okay.
That's all right.
I try again. So. Like this, is it better?
Yes, I think,
okay,
yeah, perfect.
So, let me see. Okay, I hope we can see this now. Okay, so this is Marburg. It's a little bit north of Frankfurt, in the middle of Germany. This is our university hospital, which is a quite big building. It's a little bit outside of the city, and as you can see, it's a rural area, so patients often come from far away, also because of epistaxis. I was asked to talk about risk factors for epistaxis and also about assessment. So risk factors for epistaxis, in most cases, there's just none, because 3 out of 4 children experience epistaxis at least once. And the lifetime prevalence of epistaxis is about 60%. And as you can see with these both numbers, already there's a discrepancy. Probably children forget at some time that they had epistaxis. And then only about 6 to 10% of patients seek medical advice. Out of 100,000 inhabitants, only about 120 have epistaxis in a year, and only 5 of these have posterior epistaxis. And the mean age is about 53 years. However, it's very important to remember there's 2 peaks of epistaxis. On the one side, patients younger than 10 years, and on the other side, patients older than 70 years. Out of 200 visits to emergency department, about 1 to 2 have epistaxis. So it's a reasonable number or important number. And out of these patients, 5% get to admission, to become inpatients. And out of the inpatients, the vast majority is older than 65 years old. And about 1/3 of these patients get anticoagulants or antiplatelet drugs. So these are some basic numbers for risk factors. And talking about risk factors, there's also a risk factor in anatomy, which I would like to explain. You all remember the main blood supply of the nose is the Senopalatine artery and the anterior and posterior admit artery. There's additionally also the greater palatine artery and the labral artery. And then there's this area, the Kisselbach area in the front, which is a vast vascular plexus, which is very vulnerable. I don't know if you ever met Mr. Kisselbach. Mr. Kisselbach is this here, and he was an ENT guy like us. And this is his wife. And if you're looking for fame, maybe you should be interested that you should know that Mrs. Kisselbach, she was a social politician and female activist, and her Wikipedia entry is a lot longer than Mr. Kisselbach's. So if you're looking for fame, maybe you should change your subject from Epistaxis to somewhere else. So this area of Kisselbach in the front of the nose is very vulnerable. So if you touch it, for example, by nose picking, it starts bleeding. This is already one of the main risk factors, trauma. Then there's, of course, other trauma like foreign bodies. Then, as I addressed already, anticoagulants and antiplatelet drugs play a role. Also, something like Viagra plays a role. Glucocortic nasal sprays, other nasal drugs, especially oxygen, causing mucosal dryness, cocaine or NCPAP. There's inflammatory reasons, structural changes. I already talked about mucosal dryness, but also septal perforation. And then I later on address also hereditary hemorrhagic telangiectasia. There's hematological diseases like thrombocytopenia, hemophilia, von Willebrand-Jürgen syndrome. There is a big discussion how much, which role arterial hypertension plays. So there's that may be also white coat effect. And of course, in some reasons, you have to think of, in some cases, you have to think about neoplastic and vascular anomalies inside the nasal cavity or paranasal. The first slide I'd like you to remember these different things if you see a patient. Regarding assessment, there is no uniform guidelines. However, there are guidelines. There's a British guideline. The consensus conference, I think, was headed by Carrie. And then there's an American guideline and 2 French guidelines. The first thing, especially in these times, is with COVID-19 is to protect yourself. So you have to go for contamination control. Remember the 3 Gs, gloves, goggles, and gown. And of course, you need an appropriate facility and an appropriate training. Remember, it's a bloody thing, so protect yourself. Then, if you see the patient, the first question must be for yourself, is this an emergency? Do I have time or not? Does the patient require prompt management? So it may be necessary to do even resuscitation. You might think about a vascular access and also to check for hemoglobin level. If you think that the patient had lost a lot of blood, you might take the blood pressure, you might take an ice pack or digital compression to at least stop the epistaxis temporarily so that you can prepare everything and take a history. The digital compression that is recommended in the US guidelines is shown here. This is from the publication there. And there's already set something for a list to guide further future studies. That is, determine optimal duration and technique for digital nasal compression to stop an active nosebleed. And I'd like to show this picture because I recommend I have to do a lot of with patients who bleed regularly with HHT. And I'd like to show you my way how to do this. And I don't know how can I change back to the main screen. I think like this. Yes. So okay. I hope you can see me again. Is it possible? Okay, good. So I'd like to prefer, if you're trying to explain this to the patient, my method is really grabbing back further. So you might see this from the side, so that I can touch the bony aperture. By this, the region that you compress is a lot bigger. So I prefer this. So back to that. Okay. So does it continue? Yeah, okay. Then regarding history, we were already talking about etiology. And so you might ask for medication if there's a recurrences, family history, concomitant disease. Then you start with the clinical examination. There's a recommendation for cleaning. I would recommend very careful because you don't know what you're going to expect with recurrent epistaxis. And after cleaning, we see here. This is, like you can see on the MRI, this is a venous malformation. And if you're starting cleaning vigorously, in these cases, you might get into real trouble. So you might be careful with that. And in this case, of course, after cleaning, you might start just with the packing and go over to imaging studies, like for other neoplastic diseases, trauma, whatever. So after cleaning, if you're doing this, you might go also for decongestion with local anesthesia. You go for anterior endoscopy and have a look to see the bleeding site. If this is not sufficient, you move over to nasal endoscopy. And of course, you're searching for the bleeding site or for vascular lesions like these venous malformations, or for telangiectasis, which I'll address next. You might also, if there's something like in the history, if there's something like special medication like anticoagulants, you might go also for coagulation studies. However, that's the main assessment. Regarding telangiectasis, I'd like to show you the difference between normal telangiectated vessels, like you can normally find in locus Kisselbach, or in HHT. These ones are long and straight, and these ones are more round, at least in most cases. And these are the pathophysiological mechanism of the disease. They can be found all over the body. So if you see a patient with telangiectasis also on the lips and on the tongue or in the face, or on the fingers, this may be HHT. As I said, this is a pathophysiological principle. This is such a simple telangiectasia in the mouth. This is a normal capillary loop, and this here is a telangiectasia, which you can see here as a red dot. So how it works, how these are developed is from the normal capillary bed, you get these dilated vessels, and they form a shortcut between arteries and veins. And the same principle is all over the body. So you can see it here inside the right lung. This is an arterial catheter going into arteriovenous malformation in the lung, going back, a pulmonary arteriovenous malformation. And I'd like to address this because these patients don't need just a normal assessment as we are talking about before, but something special. Because these arteriovenous malformations, they place a hole in the filter of the lungs. And so if you're getting some bacteremia, like just professional tooth cleaning, these bacteria can go through the lungs and from there to the brain or to the liver, for example, and cause abscesses. So these patients need an antibiotic prophylaxis, and even better, you might think about closing these. As I said, abscesses, or there might also be emboli going through there and causing, for example, cerebral infectations. And so these patients should be screened, especially for the lungs. And this is also something I'd like you to remember. This screen that is showing the systemic disease HHT, and to remember HHT, the clinical criteria, I'd like to show you this picture. These are the so-called Kurosawa criteria, the clinical criteria, and includes the term HHT, hereditary, that means it's an autosomal dominant inherited disease, so at least you have one, normally you have one relative of first degree that is also affected. Then you have recurrent spontaneous nosebleeds. You have multiple typical telangiectasia. So this is the term HHT. And then the fourth thing you have just to remember, I hope that you can remember by the pictures I was showing you about the lungs, there's a visceral involvement. The most important is the lungs, because you should screen for those. However, there's also cerebral involvement, cerebral vascular arteries, vascular malformations, sorry. Then you have hepatic vascular malformations and gastrointestinal bleeding. So these are the things I'd like you to remember: HHT, the Kurosawa criteria, hereditary hemorrhagic telangiectasia, and visceral involvement. If you have at least 3 positive signs, then you can already set the diagnosis. And then if you have suspicion of HHT, please think about screening for the lungs. For example, this means also for epistaxis, if you have put in a packing inside, this may already cause bacteremia, so you might think about giving antibiotics. So if you remember this, I'll be happy. Many thanks.
Urban, thank you very much for that talk, and you covered that subtopic of HHT beautifully for us, because that really is key in the assessment of recurrent epistaxis. We'll remind the attendees that questions will be at the end, so please feel free to start asking some questions. We'll do it anonymously. We won't name you at all, so we're delighted to have any questions that you might have. We're now going to move on to Gwijde Adriaensen. So good evening, Gwijde, and we look forward to your presentation.
Good evening, everybody. I hope you're comfortable and well. And thank you, Sean, for inviting me to give this webinar. Let me share my slides. Can everybody hear me? Good. Now, the idea was not to give you too much textbook material and more top tips on stepwise treatment options. So that's what I'll try to do in the coming 15 minutes. And I focus more on the epistaxis per se than the underlying diseases. And basically, when treating epistaxis, it all comes down to where does it come from? And while you're figuring that out, you always have to think about why does it bleed? And at least to me, it translates into two main principles of success in treating epistaxis. The first one being location, of course. Where does the bleeding exactly come from? And then the division between medical and surgical epistaxis. And what I mean with that is in the broadest sense possible. So medical epistaxis, is there anything I need to take care of outside of the nose? And surgical epistaxis, what is the most effective, least invasive procedure I can do to stop it? Also, it's good to realize that, well, epistaxis is nothing else than another defect in the barrier function of the inner nasal lining, and it heals in three phases of hemostasis: vascular spasm, formation of a platelet plug, and then the blood clotting cascade, within the end, fibrin, stabilizing the plug and making a mature clot. And all our interventions that we do to try to stop this epistaxis is intervening in these three phases in a positive way. So for example, the PEC is some kind of vasoconstriction, and if you put it in the right position, it also functions as a plug. So on to treating the epistaxis. But first, one always has to make sure that the patient is hemodynamically stable and get some vital signs. And for example, if the blood pressure is really high and you did your verbal anesthesia and you were very relaxed and calm to the patient and you did your intervention and it's still high, I don't think there's anything against giving a little bit of nifedipine, for example. And then the pointers towards success. First, location. Of course, the closer you are to the bleeding point, the more successful your intervention. And that might sound very obvious, of course, but it's not always as easy to do so. And I'll give you some pointers to being more successful in finding the location. These two actually. The history, of course, the assessment, we talked about it, but in finding the location, the very, very start of the epistaxis is the most important of the whole story. Not the towels and the buckets and how long it bled and how red the carpet was, but the very, very start is where you can often discern whether it's left or right, anterior, posterior, and arterial or not. And then, of course, once you have a general idea where, you go into focused inspection. And also this part is very obvious, but very, very important. So take your time to look and look before applying local vasoconstriction. Careful suctioning, at least get a little idea of where it's sort of coming from. Take your time. Then use some decongestant, some anesthesia. I always use simultaneously tetracaine, and look again. Endoscopically preferably, And use a 30-degree endoscope, for example, because you can beautifully look around corners and all the edges. And for example, a colleague of ours in the Netherlands, in a non-academic setting, he was able, in a 10 years period, with a nice setup, to treat 418 epistaxis patients and find in 98% of the cases the location and coagulate it. So it's worth your while to really spend time here. Doing the endoscopic inspection, search, but also specifically look at the region of the sphenopalatine foramen, the septal branch of the sphenopalatine artery, the branches towards the tails of the turbinates, and also have a good look at the region of the septal branch of the anterior ethmoidal artery. It's located a little medial towards the axilla of the middle turbinate and then a little bit more posterior into the olfactory cleft. And there you can find lesions like shown on this picture. They can bleed really fiercely, but you have to look for it. You might even have to manipulate the middle turbinate a little bit, otherwise you won't see them. The closer you are to where it's bleeding from, the more successful your intervention. So please do so. So let's say you find it. Then you treat it. Cauterization, always, in my opinion, if possible. You can do it chemically. It's more preferred for anteriorly located lesions. Silver nitrate or trichloroacetic acid, for example. The latter one is more fierce, so I always use an ear speculum to really isolate the region where I want to apply it. And diathermy, monopolar, bipolar. Of course, monopolar gives more electric spread, but I really like the disposable monopolar suction. You can bend it, and if you know the location, it suctions at the same time, and you buzz the place where it's coming from. Of course, you can put it on there too long, but if you put it with little bursts right at the location, I find that you're actually also causing a plug, a hemostatic phase, on top of your lesion. Works really nicely. Then, to pack or not to pack. It depends really on how sure you are that you've got the cause and you fixed the cause. If you're very sure, you don't even need to pack. If you want to pack, there are two options: soluble materials, non-soluble materials. Soluble materials is some form of local hemostatics. The nice thing about these things, and for example, we use Surgicel and Sponcostan. Surgicel is a cellulose and Sponcostan is a gelatin sponge, but we also use them for packing purposes. So the mechanical pressure property is important here. The nice thing about it is you don't need to remove it. So it's excellent for people with a drug-related epistaxis, for example. But as the periphery dissolves, less pressure over time. Not with non-solubles, they keep the pressure. But it's a foreign body, so be sure to put some anti-inflammatory, antibacterial ointment on this non-soluble tampon, whichever one, and leave it for at least 48 hours. In that case, I don't think there is a high risk of getting a toxic shock. And also importantly, I don't think we really have to admit a patient with a PAC. The PAC per se is not the reason. So non-soluble and soluble. If you pack correctly, you close down the nasal cavity. But of course you have to pack it in the right way. Not like the upper right corner. Use a Merocell or a 2 centimeter gauze, whatever. But try to stay clear, please, from balloons. And please don't do anything like this poor man on the lower right side. Balloons, don't do it. The pressure is very hard to control. You can get really nasty complications like these ones. And they're very difficult to treat. These defects in the nasal vestibule are very difficult to restore. And I don't think it's necessary. So, solubles. We were already talking a little bit about them. They are some form of local hemostatic agents. And actually, the interest in these agents sparked, at least for treating epistaxis, because of the desire to manage these epistaxis patients without the need of admission. But honestly, I think we don't need to admit a person with a PAC, not for the PAC. and then they're just really expensive. But what they do, they stimulate and augment the coagulation cascade in some way. And you have all these different types and subcategories of these local hemostatic agents. These are those. They all act at different points in this coagulation cascade, but they all have their own side effects as well. Some examples: evidence in epistaxis population is limited, but I'll give a little bit more about tranexamic acid because a little bit more is known about that. It is an antifibrinolytic agent, meaning that fibrin, the last part of this clot, making the mature plug, so to say, is broken down not as easily as normally. There's been a Cochrane at the end of 2018 on this subject, and it only found moderate evidence that tranexamic acid, oral or topical, plus the usual care, reduced the risk of rebleeding within 10 days, and the evidence for topical tranexamic acid in epistaxis alone was low. But also there was a rhinology review, a systematic review in 2016 of antithrombotic therapy in epistaxis. So in this population, drug-related epistaxis, they say there might be a role for topical tranexamic acid in patients. And if you think about it, that actually might make sense, because if there's anything, well, therapeutically wrong with this cascade, these people are anticoagulated, it might actually help to put some local coagulation promoting stuff in there as well. Which leads to the antithrombotic therapy. I'll tell a little bit about that, because up to 60% of admissions for epistaxis by now use antithrombotic therapy. It's a big group of patients, and this is a checklist of things that are helpful when you're dealing with antithrombotic drug-related epistaxis. Always identify the reason for the therapy and do a comprehensive risk assessment prior to withdrawal. Can be really risky in an atrial fibrillation, especially if there's a heart attack in the last 3 months. Get a consultation, know what you're doing. Do some cases for workup, have an INR in case vitamin K antagonist, coagulation screen, maybe. And if there are direct oral anticoagulants being used, it's always helpful to contact local hematology for advice. Systemic tranexamic acid is unproven in this population, but there might be a role for topical. Little data though. So the first group of these people are the antiplatelet users. And unfortunately, withdrawal of this medication doesn't do a thing in epistaxis because it takes up to 1 week for platelet normalization function to normalize. Platelet transfusions can be thought of, but there's no strong evidence for that now. However, if you give healthy volunteers a week of aspirin and clopidogrel and then platelet transfusion, that's how they did the study, it works to some degree, and more in aspirin than in clopidogrel because of the way it works. Vitamin K antagonists, it depends really on the INR what to do with it. And this is just some sort of guideline that you can use in order to tackle the medical part of this epistaxis. So you can continue it if you can control the bleeding, of course. Above 6, reverse with vitamin K intravenously. Above therapeutic range, but below 6, may be managed with withholding the drug if you can cover the time. And life-threatening bleeds, it is advised to reverse them with prothrombin complex concentrate together with vitamin K. And then finally, those direct oral anticoagulants, more and more they're being used and more difficult they are to treat. We have direct thrombin inhibitors, the dabigatran and the factor 10A inhibitors with roxaban, apixaban, edoxaban. Fortunately, they have a very short half-life, so withholding them can be very effective. Reversing their effect had been a little bit difficult. For the dabigatran, there is this monoclonal antibody, which really makes an irreversible complex secreted by the kidneys, and then that's it. But of course, in case of renal failure, it's very difficult to know how well it works And also the therapeutic range is difficult because not all these direct anticoagulants give specific results on bleeding tests. So it's very hard in case of renal malfunction. And then you have the 10A inhibitors. Up until recently, there was not too much you could do about them. And now they say, yes, well, you can use andexanet alpha in reversing it, but it only works temporarily. And that is because it's sort of competitive with binding towards the inhibitor, competitive with your own factor 10A, but andexanet has a very short half-life again. So if you give a bolus, then 4 hours later, the effect is gone and up goes your anticoagulative state again. And then they advise to use prothrombin complex concentrate in life-threatening bleeding, even though there is not too much evidence in this epistaxis population. So that's the medical part. Getting it all together in sort of a what to do when. If you have a bleeding patient and it's non-drug related, of course, localize and do it well. Take your time. If yes, cauterize, pack, maybe. If you cannot localize, pack, yes. If it doesn't work, go to Professor van Zele. If you have a bleeding patient, drug-related bleeding patient, actually the attack or the way to approach is exactly the same. Cauterize, yes, if you can find the location. Very carefully though, but do it. And then I would advise to pack some soluble material against there as well, just to be sure. If you can't find it, pack. First try soluble, because then you don't need to remove it again. Doesn't work, pack with non-soluble. Doesn't work, progress to talk number 3. And this gives you time to manage the coagulative state, if necessary. And maybe here, I think maybe here's a place for the local hemostats. But honestly, I myself aren't using it yet. And then, of course, you have the non-bleeding recurrent cases, which are very difficult. But basically, still, it's all about location. And look, and you often find a spot where you can think logically, this is where it had bled, and then cauterize it. And if you can't find it, advise the patient to come back while it's bleeding, so you can search again. Often these patients are in and out, and they're tired, and sometimes I just admit them a day. If they say it's daily and you can't catch it and it's daily, admit them and go to them immediately when it bleeds. And if that doesn't work and you really need to do something, you go to the OR for inspection. And also check the coagulative state. And again, here, if something is wrong or they're on antithrombotic therapy, but they're not bleeding, there might be this place for local hemostats. So that's sort of rounding it off. That's what I wanted to share with you. And I thank you for your attention.
Ida, thank you very much indeed for your presentation. We'll move on to Thibaut now in order to keep to time. So Thibaut, over to you. Thank you very much.
Hello, good evening. I'm Thibaut van Zele from Ghent, Belgium. Thank you, Sean, for also giving me the opportunity to share my vision on what to do when all these previous measures like packing fail. I will share my screen. Do you see my screen?
Not yet.
Not yet, no. Yeah, come through.
Okay. Is it visible? So, of course, what we want to avoid is, of course, long and multiple days of an aggressive packing. Like Gwijde told already before, these balloon packings can give very nasty complications, especially where you have the vestibulum, where those legs of these balloons are compressing the skin of the vestibulum. But also if you look inside the nose, which has been packed with a balloon for multiple days, you really see a very big ravage of this nose, where you see a lot of fibrin deposition and clot formation. And it's at that moment, then for the surgeon, not always easy to locate again the exact location of the bleeding. So I think one of the most important messages is that you have to avoid a long and a aggressive packing. So what can we do when...
But you're on presenter view now, so we
sorry.
see, maybe you can do it full screen, sorry.
Wait, but it's, I think, because...
That one.
No.
Oh. I'm sorry about that.
Sorry, yeah. Is it now correct? Yeah.
It'll do. That's good.
Okay, sorry for that. So what can we do when packing fails? Well, first of all is that you have to look for a bleeding from the septal branch of the anterior ethmoidal artery. We can do an endoscopic sphenopalatine artery ligation, which is abbreviated as SPAL. You can do also external ligation of the anterior or posterior ethmoidal artery. And you can do also selective cauterization if you can locate the bleeding, especially in regions of the nasal floor or inferior turbinate. In our opinion, embolization and internal maxillary artery ligation are rarely needed. Sorry, but... So when can we do this kind of procedures? First of all, if posterior packing is failing, and we know from the literature that posterior packing fails in about 1 in 2 cases. In our opinion, also recurrent episodes of severe epistaxis can be an indication to do a surgical ligation of the artery. And there are now more and more discussion as to put the sphenopalatine artery ligation or vascular management as really a first-line treatment of severe epistaxis. And there have been some criteria that can be used for indicating a sphenopalatine artery ligation, and it's called the Waxham criteria. So if you have a severely posterior epistaxis, which is uncontrolled by packing, if there is a hemoglobin drop of more than 4 grams per deciliter, or a blood transfusion required, if you have 3 episodes of recurrent epistaxis requiring repacking during a single admission, and also if you have repeated hospital admissions, I think it's quite obvious that then you should consider a surgical management. And I think it's important that we are not going into, let's say, the situation of having 3 episodes of recurrent epistaxis or multiple hospital admissions. So like our 2 previous presenters showed, it's very important to do a systematic examination and to really locate the bleeding. So you can use a rigid nasal endoscopy because you can suction at the same time with your second hand. And it's important to examine the areas where you can expect the bleeding, like the floor of the nose or the inferior meatus or the inferior turbinate. You have to examine the middle meatus, the sphenopalatine area, and the sphenoethmoidal recess. And then the third area, which is of interest, is the area between the anterior superior part of the middle turbinate and the septum. And this is an example of a case that we saw actually yesterday, where there was a balloon packing needed in another hospital. And you really see that in this patient, there is a bleeding in the inferior meatus at the tail of the inferior turbinate. And if you don't do a systematic examination, probably you will miss this kind of bleeding. So the first artery that we can address is the ethmoidal artery. So you have actually 2, you have the anterior and posterior one. And we know from this cadaver study that the anterior ethmoidal artery gives also branches to the septum. So it's called the septal branch of the anterior ethmoidal artery. And it's located between, let's say, the middle turbinate and the nasal septum. And it has been described by Aldo Stam as the S point or the Stam S point. And it's often referred to an emergency department as a really intractable epistaxis with intermittent episodes. And we quite often see that there have been some failures of balloon tamponade in these cases. So you have to look for these small, let's say, aneurysms that you can find between the middle turbinate and the nasal septum, so in the direction of the olfactory fossa. And what you have to remember is that you have to identify these lesions without the use of decongestant. So when you will apply decongestant, you will see that these lesions will be much more difficult to find back. And here you see some of our own cases where you have the middle turbinate, the nasal septum, and then you see this, yeah, it's some kind of vascular malformation or an aneurysm. And most of the time when you touch it, it starts to bleed heavily. And it's very easy to treat. You just use a monopolar or a bipolar to calculate this kind of lesion. So it's very rewarding to use to treat these lesions. And this is a second example from which I received from Richard Harvey, where you see that this small artery is actually giving a quite important amount of blood loss. So just use a bipolar or a monopolar to control these lesions. You can also do an endoscopic ligation of the anterior ethmoidal artery. I think this is more needed when you do this during surgery. So especially when patients have had a bleeding during endoscopic surgery or a trauma, you can try to address this ethmoidal artery endoscopically, so in the ethmoid. If it's not dehiscent, so here you see a dehiscent ethmoidal artery. If it's not really dehiscent, you can try to open up a small part of the lamina papyracea and then try to coagulate this artery inside the orbit. Important to know is that you should avoid the use of monopolar because you can have also a CSF leak, so it can be surrounded by a little bit of dura. So by using this high amount of energy at the skull base, you can cause a CSF leak. A nice technique to also address the anterior ethmoidal artery is by doing a pre-caruncular approach. This avoids a scar which you have when you do this kind of Lynch incision. So if you just look for the caruncula, you do a small incision of 0.5 centimeter anterior to this caruncula. You will also get into this subperiosteal plane, so when you're outside the periorbit, and you will be able to locate both the anterior and posterior ethmoidal artery. You can clip this artery or you can coagulate it, really doesn't matter. And this is really a very easy and quick technique for addressing the ethmoidal artery through a small incision, and it's really not needed afterwards to put a stitch on this. Now, the most important artery for surgical ligation is the sphenopalatine artery. We know that this artery comes from the external carotid artery and is a branch of the maxillary artery. We have to remember that the sphenopalatine artery comes out of the sphenopalatine foramen, which is located between the palatine bone and the posterior wall of the maxillary sinus. And in most cases, there is not a single artery, but when you look at the number of arteries which is already inside the sphenopalatine foramen, you will see that there are in most cases 2 to 3 arteries which give branches to the middle turbinate and at the anterior face of the sphenoid sinus. Now, if you want to do a vascular ligation of the sphenopalatine artery, there are 3 important key points that you have to remember. First of all, you have to do a subperiosteal elevation of the mucosa so that you can really pull these vessels out of the foramen. The third important point is that you have to look for the crista ethmoidalis. The crista ethmoidalis is a small bony prominence of the maxillary bone, which is really pointing you towards the sphenopalatine foramen. and in most cases you will have the artery located just be inferior or behind this crista. So this is really a guide towards the sphenopalatine foramen. And thirdly, you have to look for multiple branches of the sphenopalatine artery. So you really have to dissect all the vessels out. So here you see a branch, here we have a branch, and here you have a branch. So you really have to coagulate or clip all the different trunks of this sphenopalatine artery. You don't need a lot of fancy or expensive equipment to do this sphenopalatine artery ligation. So a bipolar, let's say a ball tip seeker, a freer or a Cottle elevator or a suction freer is really enough to do this kind of procedures. And here you see a small video of this procedure. We, let's say, don't open the maxillary sinus, but it's perfectly okay that you first open up the maxillary sinus. Here we are in the middle meatus of the left nasal cavity. And what we do is with a sharp edge of a freer, we make an incision, try to get immediately in the subperiosteal plane. And we do this incision a little bit before the attachment of the middle turbinate. Of course, it starts to bleed a little bit, but when you put cottonoids with 1 in 2000 adrenaline, you can control this bleeding. And then if you are in the right plane, you will easily find this crista ethmoidalis, and when you start to pull on this small flap, you will see that you are able to pull this vessel out of the sphenopalatine foramen. And then it's just a matter of taking your time to dissect all the different branches of the sphenopalatine artery. And we just coagulate, so we don't use clips. What we actually do is that we also cut the vessel to avoid revascularization. And then you just continue to look for more branches of the sphenopalatine artery more posteriorly towards the anterior face of the sphenoid sinus. And at the end, you just have to put a little bit of resolvable packing. This is Surgicel that we put in the middle meatus, and it's all needed for packing. And we wait for 24 hours to, let's say, let the patient go home. So what are the complications of sphenopalatine artery ligation? They are quite rare. So you have a little bit of dryness of the nose, but it's really not an issue with most of the patients. And there have been very rarely described paresthesia or hypoesthesia of the upper teeth or the nose. And it's actually a procedure that every ENT or, let's say, sinus surgeon has to have in his hands, especially when you're doing also more advanced surgery. It's really an essential let's say, technique you have to learn. More rarely, you can do a ligation of the maxillary artery. You can find this maxillary artery behind the posterior wall of the maxillary sinus. So if you start with a, let's say, Carrie forceps, opening up the sphenopalatine foramen and then going a little bit laterally, you will see the periosteum behind the maxillary sinus, and when you incise that, you will find a very, let's say, curving big vessel, which is the internal maxillary artery, and you can clip or coagulate also this artery. Embolization is the last vascular intervention you can do. You have to keep in mind that you can only embolize branches of the external carotid artery, so it's not, let's say, useful for ethmoidal arteries. There have been studies comparing endoscopic sphenopalatine artery ligation versus embolization, and actually we see that they have the same long-term success rate, about 75% in this study, but embolization carries a greater risk of important complications compared to sphenopalatine artery ligation. And these complications can be really devastating, like a cerebral infarct, arterial dissection, and necrosis of the face, and are present in from 6 to 47% of the cases, there are complications with embolization. Now, if we look at the success rate of all these kinds of surgical interventions, we see that sphenopalatine artery ligation has a very high success rate of 85 to 98%. And if you add a ligation of the ethmoidal artery, you can really achieve 90 to 100%. Also, an internal maxillary artery ligation has a high success rate of 87%. We also did a small retrospective study in our hospital, and we saw that anterior packings are successful in 70% of the cases, but you see that there is a very high failure rate of posterior packing, so more than 67% of the packings fail. And all these patients go into a vascular intervention. And if you then see what kind of intervention that we need to do, is that in the majority we have to do a clipping of the sphenopalatine artery. In 20% we see this stem S point of the ethmoidal artery branch, and it's very rare that we have to do a clipping of the maxillary artery. And since 2013, we actually have never embolized or needed embolization to control our epistaxis patients. Also, if you ask the patients what they prefer, you will see that if a patient has had both a packing and a surgery, if you ask them for how they tolerate this procedure, you will see on the VAS score that they will prefer surgery above packing. And also, if you look at the VAS scores of how painful the procedures are, you see that surgery is really much less painful than a balloon packing or a rapid rhino packing. So patients really prefer surgery above these long or aggressive packings. And also, if you look from a cost effect,
I think we're probably going to have to wind up now.
This is my last slide, I think.
Okay.
Okay. So from a cost effectiveness point, we know that sphenopalatine artery ligation is much more cost effective or cost saving, especially when you have to pack for 3 days or longer. So to conclude, I think it has been said before, so we have to identify the bleeding and coagulate. You know that sphenopalatine artery ligation has emerged as an important treatment in the management. It is a low morbidity procedure with a high success rate. And of course, look also for the S points between the middle turbinate and the septum, and only perform embolization in very selected cases. So I thank you for listening.
Thank you very much indeed for that comprehensive discussion about the place of arterial ligation. Pavol, I think we have some questions. Can I just encourage anybody who was waving their hand during the presentation to put that into a question for us, please?
So thank you again for fantastic presentations. The first question would be addressed to Thibaut van Zele. I would like to ask, this is from the audience, what is the recommendation regarding the use of monopolar coagulation in a posterior epistaxis control?
So if you do a vascular, let's say, control, and you identify the vessel, so you look for the sphenopalatine or the ethmoidal artery, I think it's more useful to do a bipolar. But of course, if you see this vascular anomalies at the septum, you can easily use monopolar. So the case in the inferior meatus, we used monopolar, or even argon plasma we used. If you have this S point, you can perfectly use monopolar. You just have to be careful by using monopolar at the skull base, so that you don't create a CSF leak there.
So we had 2 patients with a transient soft pellet numbness when we used the monopolar in the area of the SPA ligation. Mm-hmm. Have you ever experienced that?
Yeah, we also have this kind of neuralgia with one patient where you use a lot of monopolar around the sphenopalatine foramen. We call it in Belgium a sluderneuralgia. So we really, if you can locate the vessel and dissect the vessel, I think it's better to coagulate it with a bipolar or to put clips on it. But if it's a mucosal bleeding, I think monopolar is perfect.
What is your setting for monopolar and for bipolar?
So we put the bipolar hits on 20, and the monopolar it's sometime between 12 and 20. So
12 and 20.
Yeah.
Now, my last question on the surgical area. Would you consider for the recurrent epistaxis bilateral SPA ligation if it is mostly from one side due to the crossover from the other side? Or do you always perform only one-sided procedure?
So we really look for the history of the bleeding. So in most cases, you can really locate the bleeding, first of all, based on history, if it's a left or a right-sided. We actually never needed to do a bilateral sphenopalatine artery ligation. So I really question when it's really necessary. I think it's the same with bilateral packing. We also stopped performing this bilateral packing. So.
Now, I would like to ask a question on Gwijde Adriaensen. Thank you again for the fantastic presentation. You mentioned the tranexamic acid and the role for the treatment of the epistaxis. Do you use that in as the treatment of the first contact? To use it for patients for a mild epistaxis, for example, SOG neuropathies? In the emergency room, or do you reserve it for more severe cases?
Well, personally, I don't have experience with using it, as I told, but seeing this whole schematic and where it could fit in, I think you could use it, and then especially in the anticoagulated patient. And then, for example, if you decide to pack, I've read studies where they say they dip the pack into the parental solution of tranexamic acid and place it. I have no experience doing that because for me it works with the way we pack, and then proceed if necessary to surgery, yes or no. But maybe there could be a place to use it, but I don't have it readily available where I work.
Can I ask Urban a question? I was intrigued by your discussion about screening patients for HHT and other vascular malformations. Can you tell us in your institution how you go about screening? What do you do practically?
Oh, practically, there's also these international guidelines. And the international guidelines recommend to look for pulmonary artery malformations. And we do this by echocardiography, transtoracal echocardiography with contrast material. So it's an easy thing. So you look just if the contrast material just isn't inside the right, but also goes into the left heart. That shows that there's something like a filter defect in the lungs. If this is positive, we move over to a CAT scan of the lungs to see if these pulmonary arterial venous malformations are worthwhile to embolize or not. We also will try to move on to MRI of the lungs, but in the moment it doesn't work at our institution, but we hope we get over to this. When I was before in Hamburg at the Saarland, there we were able also to do MRI, so there's no radiation exposure, but we didn't establish this here.
So for all our attendees who perhaps see patients with HHT, should they be screening first-degree relatives as well? Yes, exactly. If you have a patient that for sure has HHT, you should also screen first-degree relatives. And also another option, of course, is molecular genetic testing. So you, by this, however, molecular genetic testing has only a so-called mutation detection a percentage of about 85%. So if you have an index, if you don't find an index patient with a mutation for sure, yeah, then it may, you don't know if the family has HHT or not. So it may be difficult in this case. However, if you found the mutation somewhere in an index patient, then you can test the rest of the family with that too. You might also, for this, you might also have to have in mind, there may be something like a genetics testing law in your country. So in Germany, if you're doing genetic testings on children, this may be a big financial disadvantage in the future. So if they try to get something like a health insurance or something like this, then they might get problems with that. So that's something you have to look in your country. Regarding tranexamic acid works very well in HHT. In Germany, it's even government approved
so we can prescribe tranexamic acid tablets to patients with HHT to stop the recurrent epistaxis. You can also use it locally. There's a study on this, a nose study from the United States, where they didn't find a significant effect of the spray of tranexamic acid into the nose. But I know patients, not only in Germany, but also in other countries, which either use tranexamic acid cream or use tranexamic acid as a liquid to get it into the nose. And they say it helps also like this.
It sounds like we really ought to have a webinar on HHT. There's a whole topic there in its own. Yes. I'm just conscious of the time. It's 8 o'clock. I think we should end our webinar there. I'd like to thank all our panelists for their contributions. I know how much time it takes to prepare presentations, and I'm very grateful to you and to everybody in admin at the ERS who have enabled this to take place. Our next webinar will be in 2 weeks exactly, on the 16th of July, on Thursday evening, and we'll be doing a round table on complications of rhinosinusitis. So we will advertise that and look forward to seeing you again at that. In the meantime, I don't have anything more to say other than the fact that this will all be uploaded onto YouTube. And so from us all, good evening and goodbye.